Good afternoon, everybody. Welcome to Cancer Reach. So, Cancer Reach is initiated by Dr. Krishnamani to spread awareness about cancer and help the caregivers to access the right treatment on right time. Dr. Krishnamani is a renowned medical oncologist and has more than 10 years of experience in the oncology segment and has done his DM from the prestigious Institute of Telugu State Nizam Institute of Medical Sciences, also known as NIMS. Currently, Dr. Krishnamani is associated with American Oncology Institute, Hyderabad. So, as you all are aware, that September is known for Ovarian Awareness Cancer Month. So, ovarian cancer is the seventh most common cancer in the women in the world. And as per statistics, it says 1 in 75 women is diagnosed with ovarian cancer once in their life during their lifetime. So now I hand over the session to Dr. Krishnamani to enlighten us more on the treatment, recent advances, and future landscapes of ovarian cancer. Over to you, sir.
Hello, thank you, and hello everyone. Hello to all our viewers. Welcome to Cancer Reach. And as has already been said, Cancer Reach is an initiative to spread awareness about cancer. This is part 2 of our series of ovarian cancer, this being the Ovarian Cancer Awareness Month, and this will be the final series on ovarian cancer. So let's summarize a few things which we discussed the last time and go into some newer areas or newer therapy or treatment areas in ovarian cancer. So ovarian cancer per se is a very common cancer which we see in the women. Usually seen in the elderly, but it is not uncommon to be seen in young women. So it is, we see young women with ovarian cancer too. And ovarian cancer is kind of an aggressive disease. And most of the time it presents in an advanced stage. Many women usually are asymptomatic, or many women usually do not know the symptoms by the time the disease is advanced. So there is no way, or there are no screening methodologies right now, like for breast cancer or for cervical cancer, which are recommended for ovarian cancer. So by the time a woman is diagnosed with ovarian cancer, she's usually in an advanced stage, usually in stage 3 or stage 4. By that time, what happens is the disease usually spreads in the abdomen, in the tummy. There is some fluid in the abdomen, which is called ascites, because of which these women complain of bloating, early satiety. That is, they take a little bit of food and they feel they are full. There is a fullness, there is constipation, there is pelvic pain, sometimes bleeding, and those kind of issues. So by the time the disease presents, it's usually late, usually stage 3 or 4. Difficult to detect the disease early, unless coincidentally we go for a master health checkup or for some ultrasound or some scan for some other reason, and you pick up a pelvic or a ovarian mass. CA-125 is a very common blood test which is done in ovarian cancer. But what we should remember is CA-125 is elevated in only 70% of ovarian cancers. That is, 30% of women can have ovarian cancer but have normal CA-125. So what it means is a raised CA-125 is not always ovarian cancer, because CA-125 can be raised in non-cancerous conditions also, like pregnancy, menstruation, adenomyosis, etc. So raised CA-125 is not equal to ovarian cancer. At the same time, if you have a normal CA-125, but you have other symptoms and investigations which are supporting ovarian cancer, just that you have a normal CA-125 doesn't mean you don't have ovarian cancer. So that is the issue with CA-125, that it cannot be routinely recommended as a screening test. Now, suppose you start doing CA-125 randomly, and If it is slightly raised, the normal value is less than 35. If it comes as 38, then what does it mean? Does it mean you have ovarian cancer? Does it mean you have to go and start yourself and getting tested, do ultrasounds or CT scans, etc.? Number one. Number two, the other scenario, somebody has all the symptoms, they go, they get evaluated. There is an ovarian mass on the CT scan. You do a biopsy, you have ovarian cancer, but your CA-125 is normal. So does it mean you don't have ovarian cancer? No. So CA-125 is just a blood test. It is not a routine screening test. It can be seen in elevated in normal conditions also, and it can be normal in 20 to 30% of ovarian cancers. That is what we should remember as lay people. What are the stages of ovarian cancer? So ovarian cancer usually starts in the ovary, then it spreads to the fallopian tube. It can go and involve the uterus or the other pelvic structures, and then go to distant organs. If the disease is outside the pelvis, it is usually stage 3, and if it spreads to other organs, it is usually stage 4. Stage 3 is the stage where we commonly see our patients. Most of the patients are diagnosed in this stage. They either present with the mass, or they can either present with water in the tummy or fluid in the tummy, which is called ascites. They can present with something which is called peritoneal deposits. Peritoneum is a layer in the abdomen, and this disease can form small ball-like deposits, which can also ooze fluid. So these are the ways in which patients are picked up, or these are the stages of ovarian cancer, and the stage is evident on examining the patient. And obviously, after that, we will do scans like an ultrasound or a CT scan or an MRI, which would pick up these things. Now, most importantly, how are we going to treat our patients with ovarian cancer? Surgery is the most important or the cornerstone of treatment for ovarian cancer. We should remember that. Most patients, as we discussed, they present in an advanced stage. So they will need chemotherapy initially, because it is difficult for the surgeon to remove the entire disease which is there. When we talk about surgery, we talk about removing the entire tumor and leaving very little behind or nothing behind. If you are leaving a large amount of tumor behind, that surgery is not an effective surgery. So the aim of surgery in ovarian cancer will always be to remove as much disease as possible and to leave literally nothing behind. This is called optimal cytoreduction. So you don't want to leave anything behind literally. When you present with an advanced disease, it is difficult for the surgeon to remove all the disease, because there are a lot of vital organs involved, and it may probably involve sacrificing those vital organs. So what we usually do is, in most cases of ovarian cancer, which we commonly see, who present in stage 3 or 4, you will give chemotherapy initially, which will shrink the disease. And after 3 or 6 cycles, that is maybe after 2 or 4.5 or 5 months, you will take the patient up for surgery and remove all these diseased areas. Now comes to the next question is, what is chemotherapy and how is it used in ovarian cancer? So chemotherapy, basically, to put it very simply, is a cancer killing drug. So in ovarian cancer, we usually give it with the intravenous route. It's a daycare procedure usually. You can come in the morning and go home by evening. It is given in a few bottles of saline. Takes usually around 3 to 5 hours or 4 to 6 hours to administer the chemotherapy. It can be given either once every 3 weeks, or if the doctor feels that the patient's general condition is not that fit, the 3 weekly dose is divided into smaller weekly doses. At the end of maybe 9 weeks or 18 weeks, we will see some kind of a response. The CA-125 will fall down, the patient starts feeling better, on scans your disease comes down, and then once the chemotherapy is over, we will be going back to the surgeon for a surgery. Chemotherapy, like any other chemotherapy used in any other cancer, has its set of side effects, which could range from hair fall, nausea, vomiting, mouth ulcers, loss of taste, darkening of the palms and soles, fall in hemoglobin, fall in WBC counts, fall in platelet counts, risk of infections, tingling and numbness in the hand, especially in diabetic patients, which is called neuropathy. And sometimes during the administration of the drug, patients can develop reactions in the form of fever, chills, or breathlessness, or chest heaviness. Most of these side effects can be managed. There is not to worry about these side effects. And once you stop the chemotherapy, all this comes back to normal. The hair comes back to normal. Taste is okay. Your appetite is okay. You feel better. Weakness is gone, etc. So these are side effects which last during the chemotherapy cycles. Everybody need not have the same intensity of side effects. Someone may have lesser amount of side effects. Somebody may have no vomiting, only nausea. Somebody may have body pains, etc. But they're all manageable. And these are precisely the reasons why chemotherapy is given in a hospital setting, because these are drugs which have tendency to cause adverse effects or side effects or adverse reactions. So they always have to be administered in a hospital setting. There are other medicines which are used in ovarian cancer, namely targeted therapy and PARP inhibitors. Targeted therapy differs from chemotherapy. It acts on a specific target. In ovarian cancer, this targeted therapy prevents the growth of blood vessels in the tumor, or it blocks the blood vessels of the tumor. It doesn't have side effects of chemotherapy like all we described now, like hair fall, nausea, vomiting, etc. And the advantage of targeted therapy is you start it with chemotherapy and you can continue it after the chemotherapy is stopped. Chemotherapy is usually stopped after a fixed number of cycles, usually 6 cycles, but targeted therapy can be continued thereafter. So targeted therapy is one of the advances which we have seen in ovarian cancer over the last 10-15 years. Another important advancement which we have seen in the treatment is PARP inhibitors. So before that, we should understand that ovarian cancer can be hereditary or genetic in 15 to 20% patients. And most of these patients have a mutation called BRCA1 or BRCA2, which is called BRCA1 or BRCA2. So when any patient is diagnosed with ovarian cancer, we send the tumor tissue for this test, and we also send the patient's blood sample for this test. If you have BRCA1 or BRCA2, that means you have a tendency to have ovarian cancer or breast cancer and some other types of cancer. And in these kind of patients, we use medicines called PARP inhibitors. So after we give the chemotherapy, once the disease has responded extremely well, if you are BRCA positive, you will be put on medications or oral medications called tablets called PARP inhibitors like olaparib, rucaparib, etc. by a doctor. So to summarize, PARP inhibitors or olaparib or rucaparib are oral medications given in BRCA positive patients who have ovarian cancer after they respond to chemotherapy. And they are again safer. It's a pill which can be taken at home, doesn't need hospitalization, and doesn't have the side effects of chemotherapy. And you give it in BRCA1 or BRCA2 patients. And the BRCA1 and BRCA2 testing should be done in all patients of ovarian cancer. It is done on the tumor, or it can also be done on the blood. One important thing as far as surgery is concerned is there is a type of surgery called HIPEC, hyperthermic intraperitoneal chemotherapy. So in some centers, a few surgeons may do surgery and also give heated chemotherapy during the time of surgery, and this has shown to improve outcomes. So tomorrow, if your doctor discusses about HIPEC at the time of surgery, please understand HIPEC is also used in ovarian cancers, and have a conversation with your doctor on how it can improve your overall outcome. So till now we have discussed about the symptoms, the stages, surgery, chemotherapy, targeted therapy, and PARP inhibitors. Now, how do you follow these patients? So somebody has finished 18 weeks of chemotherapy, disease has shrunk very well, you do a surgery, you do BRCA testing, treatment is over. Once your treatment is over, your patient will come and ask you, am I cured? You have completed my treatment today. Am I cured? You're only going to tell your patient that your disease is under control, or whatever we have been able to see has been removed, but you have to be under regular follow-up. So usually these patients are called once every 3 months for the first 2 years. Once you cross 2 years, and if the disease doesn't come back, we would say don't come every 3 months, start coming once every 6 months, up till 5 years. And once you cross 5 years, we would say come once a year. The word cure is usually used if your disease doesn't recur up to 5 years. And most of these cancers can recur in the first 1 to 2 or 2 to 3 years. And the chance of recurrence of an ovarian cancer is very high. So that is why we should never use the word cure after completing treatment. Number one, we should always counsel our patients that this is an aggressive disease. It can come back. So I'm going to keep you under close follow-up. And 3 months, once every 3 months for the first 2 years, and thereafter, if you're doing well, we'll increase the time period of follow-up. During follow-up, we usually do a blood test called CA-125, as we discussed, and we examine the patient. Few people, or sometimes we also do an ultrasound of the abdomen just to be cautious. Otherwise, routine scans is not indicated if the patients do not have symptoms. Imagine your CA-125 is 7. 3 months later, it comes up to 7.5. Don't get paranoid. Don't get panicked that your cancer is increased. No. But if you start developing symptoms again, your CA-125 has a dramatic rise from 7 to maybe 500 or 800 or 1000, then we are inclined to think that maybe the disease has come, and then your doctor will probably evaluate you. But from 4, if it has gone up to 8, or from 12, if it has gone up to 15, doesn't mean much. So you're going to be under close follow-up with your CA-125s. What are the precautions one needs to take as a ovarian cancer survivor or as a ovarian cancer patient? More importantly, during your chemotherapy sessions, what we advise patients is to have a healthy lifestyle, be very hygienic, gargle or rinse their mouth with mouthwashes maybe 4 to 5 times a day, have freshly cooked home food, have a lot of fiber in the diet because it helps the bowel, drink lots of water. And during your chemotherapies, your doctor will recommend you to take anti-vomiting pills or WBC booster shots to prevent infections. Once chemotherapy is over, we would want you to maintain a healthy lifestyle, a little bit of walking, yoga, or whatever you do. Again, home food, plenty of liquids, and that's about it. Nothing specific for ovarian cancer per se, but obviously we would always encourage people to have fiber in their diet. The myth that sugar or rice increases the risk of ovarian cancer or any other cancer for that maybe is actually a myth. So we would recommend most of our patients to always have a balanced diet. Now coming to the patients who are BRCA1 or BRCA2, patients who have BRCA1 or BRCA2, there are two things. One, they have a risk of other cancers in the form of breast cancer, ovarian cancer, etc. Two, their immediate family members have to be tested, that is their siblings and their kids, to see if they have a risk of, they are carrying the BRCA gene, so that they can take preventive measures to prevent breast, ovarian cancers, etc. And more importantly, as we just discussed, these patients are eligible for treatments like PARP inhibitors. Coming to relapse of ovarian cancer. So there are two types of relapse in ovarian cancer. If your relapse occurs after a very long time, or relapse occurs after a very short time after completing chemotherapy. So as an example, if somebody has completed chemotherapy in January. We call it platinum chemotherapy. The name of the medicine is platinum. If your disease comes back in April within 3 months, that's a bad disease. So any disease which comes within 6 months of stopping your last chemotherapy is a resistant disease, or platinum resistant disease, we call it. So even if your disease comes back, there are two types. One in whom the disease comes back after a very, very long time. One in whom the disease comes back early. The one in whom the disease comes later, or who has been well for a very long period, is actually doing well. She's called platinum sensitive. So in January, if my treatment is over, and if my disease comes back maybe 2 years later, I am platinum sensitive. That means that platinum medicine which was used for me initially, it will be sensitive, or it will work even now, because my disease has not recurred for almost 2 years or 3 years or 4 years. But if the same disease comes back within 6 months, it is called platinum resistant disease. So that means that medication cannot be used. More importantly, what it also tells us is your disease is behaving badly. It is coming back earlier. So you have a resistant disease. So this patient is not going to do well. But somebody who comes back after 2 years or 4 years, who's platinum sensitive, if you give the same medicine again and it works, that person is going to do well. So to put it simply, disease comes back early is platinum resistant, they don't do well. And those people who get disease much later are called platinum sensitive, they will do well. Lastly, coming to immunotherapy in ovarian cancer, or the future trends or the recent advances in ovarian cancer. So as far as the recent advances are concerned, we've covered targeted therapy, high-tech surgeries, and PARP inhibitors, BRCA testing, hereditary cancers, etc. Immunotherapy is a newer kind of medication which boosts your immunity to kill cancer, and it has been used in many cancers like lung cancer, melanoma, which is a skin cancer, urinary bladder cancer, renal cancers, etc. The whole point is immunotherapy is a step away from chemotherapy, and in certain cancers, we have had an excellent success. In ovarian cancer, it is not much of a in thing. As a desperate measure, in those patients who undergo extensive molecular testing, after using all their acceptable treatments, if certain molecular features are there, then only it is recommended, but that number is very, very small. This is a question I keep getting from most of my patients and their relatives, saying that, what do you say about immunotherapy in ovarian cancer? The role is very limited, or it is not that much in vogue right now. So unlike in lung cancer or kidney cancer, we will not talk much about immunotherapy in ovarian cancer. The bulk of treatment, or the mainstay of treatment in ovarian cancer, is still surgery, chemotherapy, targeted therapy or bevacizumab, and PARP inhibitors. So to summarize, as a part of this ovarian cancer awareness month, what I would like to tell our audience is, it's a silent killer. Ovarian cancer is a silent killer. There is no specific way you can try to beat this disease by knowing it prior, like a breast cancer or cervical cancer. By that I mean, there is no optimal screening test. Symptoms are extremely vague: body pains, back pains, abdominal pain, bloating, etc. Nothing is indicated. It doesn't mean with the smallest sign of bloating, you should rush to a doctor and think of an ovarian cancer. No, not at all. It could be a normal acidity or a gaseous distension, etc. So the symptoms are extremely vague. Screening is not optimal or not available. And it's a disease which is aggressive. It is disease which is common. Tests are there to diagnose. So when you have any of these symptoms, if your CA-125 is elevated, if your doctor sees and gets it done, and imaging is confirmatory, or scans are confirmatory of ovarian cancer, you will undergo a biopsy, and most likely you will undergo chemotherapy followed by surgery. BRCA testing is mandatory in ovarian cancer, and that is one thing which I would want everyone to understand or learn or know that today we are in that era or generation where BRCA1 and 2 testing, and it is also called HRD testing, where we do more tests, which is done on the tumor, and this is mandatory. Post chemotherapy, post surgery, patients are kept under follow-up, and the hope is that they do well, number one, and number two, to catch them early if they have a recurrence. Lead a healthy life, have regular follow-ups, don't miss your follow-up sessions with your doctor, and follow his or her advice as far as your follow-ups are concerned. With that, we wish you all well and hope you have learned something along with us too in this journey of ovarian cancer on Cancer Reach. Thank you so much.
Thank you so much, sir. Sir, there are a few questions in the chat box which the common people have asked you. So, sir, with your permission, can I ask?
Yeah, please.
So, okay. So, the first question says, what are the complications of ovary removal, and is there any hormonal changes that are expected?
So please understand, when we have ovarian cancer, surgery is mandatory, and that surgery is a complete surgery which needs removal of the ovaries. So if you're going to leave a diseased ovary with cancer behind, that surgery is not complete, which we had discussed. In a young lady who doesn't have children yet, who has not completed family or who's unmarried, then we may not sacrifice both the ovaries. We will have to leave one ovary and the uterus behind and remove only the diseased ovary, so that she has a potential for having children later. But otherwise, in an ovarian cancer surgery, removal of the ovaries, fallopian tube, uterus, etc. is a must. Hormonal changes will be there, like any woman who has who reaches postmenopausal age, like hot flushes, back pains, weakness, etc., and some bone weakness too. But then they are not very severe and they are manageable.
So the other question is, what % of women are diagnosed in advanced stages in India?
Worldwide, forget about India. Worldwide, 60 to 80% of ovarian cancers are diagnosed in stage 3 or stage 4. That's because we do not have an optimal screening test, number one. And it is not like, it's an internal organ. It's not like a breast where you have a lump and you can immediately go and show someone. Because it is internal, because by the time you develop symptoms, it is advanced, 70 to 80% or 60 to 80% of women present in an advanced stage.
And the other question, the last question, which says that, is there any chances of fertility preservation?
Yes. So fertility preservation for women is obviously there. So that is why if we have to treat a young woman with chemotherapy, as I told you, any woman in a childbearing age who doesn't have kids yet, if I have to treat her with chemotherapy, my chemotherapy is going to destroy her ovaries and her chance of developing or having children. Sorry. So in that case, we would ask them to have fertility preservation first, go meet the gynecologist or the infertility specialist, have the fertility preservations, and then that is oocyte cryopreservation, it is called, and then go ahead with chemotherapy and surgery, because sometimes chemotherapy can have a permanent impact and can prevent childbearing.
Sir, I guess we should conclude this session, and thank you very much, sir, for your valuable time. I guess the common people might have understood it really well because the session was very insightful. And so here, I guess I conclude the session right now.
Thank you. Very grateful to all our patrons. Thank you
so much, sir.